and welcome to the Goldman Berlin Lectureship in Palliative Medicine. This is our open forum, and it's one of several events that's part of this annual lectureship. And before I introduce our speaker, Dr. Ann Kinderman, in the tradition of Providence, I want to share a reflection. And this is one of my favorite reflections, but I didn't know the story behind it for a long time, and so I looked it up, and it's by Theodore Roszak. And he was inspired to create this poem by every day walking down the street, passing homeless people on the street and immigrants and people from different backgrounds, and realizing that he really didn't know them, and realizing at the same time how connected he felt to them and how much he did want to know them. And so this reflection is called You and I. You and I, we meet as strangers, each carrying a mystery within us. I cannot say who you are. I may never know you completely. But I trust that you are a person in your own right, possessed of a beauty and value that are the earth's richest treasures. So I make a promise to you. I will impose no identities upon you, but will invite you to become yourself without shame or fear. I will hold open a space for you in the world and allow your right to fill it with authentic vocation and purpose. For as long as your search takes, you have my loyalty. So Dr. Ann Kinderman, our 2016 Goldman Berlin Lecturer in Palliative Medicine, is an Associate Clinical Professor of Medicine at the University of California, San Francisco, and is the Director of the Supportive and Palliative Care Service at San Francisco General Hospital. After completing her internal medicine residency at the University of California, San Francisco, and hospice and palliative medicine fellowship at Stanford, she returned to San Francisco General in 2009 to help develop the Supportive and Palliative Care Consult Service as its founding director. Dr. Kinderman's scholarly work has included developing a curriculum in palliative care interpreting for professional medical interpreters, promoting high-quality care for vulnerable populations with serious illness, and expanding palliative care services in safety net health systems. Within the American Academy of Hospice and Palliative Medicine, she helped to create and lead a special interest group focused on the healthcare safety net, which advances collaboration and scholarship among palliative care providers caring for vulnerable patients. And she's joined as a palliative care lecturer by Dr. Meg Mullen, who's here with us and who spoke this morning on homelessness, and they will be speaking tomorrow at Grand Rounds on homelessness at Providence Portland Medical Center. So you may want to also join us for that if you haven't already heard them. They were really wonderful this morning. And just to say one more word about Dr. Kinderman, in 2014, she received a Sojourn Scholars Leadership Award from the Cambia Health Foundation to support her development as a leader in palliative care, and was subsequently named an Inspiring Leader Under 40 by the American Academy of Hospice and Palliative Medicine. So please join me in welcoming Dr. Kinderman.
Thanks very much, Barbara. I always am second-guessing myself that part in the bio now where I'm like, oh, did I just reveal my age in some vague term anyway? So I'm so pleased to be here talking on this topic, and I'm really honored that all of you are choosing to spend your lunch hour plus hearing about this. So we'll move forward. I really, the intention, my understanding of this forum is to be more of a forum and a dialogue than me speaking at you for the next 83 minutes, which would seem horrible. So what I'm going to do is kind of as we go along, create some space for you to pause and think about things or talk with your neighbor about questions that come up in caring for these patients. So here we are. I have no relevant financial disclosures. As I mentioned, as Barbara mentioned, I help direct the palliative care program at San Francisco General Hospital. And this talk and this topic area was fleshed out originally with a social worker who worked with me at San Francisco General, as well as some colleagues at Bellevue Hospital in New York. So what I'm hoping that you will get out of this next period of time today is to dig in a little bit deeper in understanding some of the unique barriers that undocumented immigrants face when they're diagnosed with serious illness, to anticipate what are the common concerns and requests that are made by immigrants who are approaching the end of life, and then to really come away with some successful strategies for increasing access to hospice and palliative care for immigrants. So what I'm going to do is spend this first chunk of time really just giving some background information that hopefully will ground us in this topic, and then talk through some cases and some real-life examples. So my father is a lawyer, and he's very interested in terminology and being very precise in your terminology, and particularly in a topic like this that can be really charged. I wanted to take a moment in the beginning of this time to just say that we use a lot of different words to talk about the same concepts, and that none of these words are completely neutral. You kind of have to in a talk anchor yourself on some of these terms. But I wanted to just to highlight that you'll hear a whole variety of things in the media and in our culture to describe the same concepts. So, but they feel very different, right? Talking about someone who's an immigrant versus an alien, like another life form that's here in the United States. When I talk about people who are here through a visa with a green card, or who are citizens who were born in another country, I'm going to refer to them as documented. Some people will call them legal immigrants or legal aliens. But one of the interesting things that's come up kind of in people who are advocates for people who are here as immigrants is to say, you know what, we don't talk about someone as, if they're skipping school, as an illegal student. So there's an interesting way that we're highlighting this issue and kind of the legality of their status in a way that's kind of unique. So I just want to raise that as a question in your mind around kind of that terminology that we use. Just to kind of ground us, for people who have been here, come to the U.S. in a kind of through a dedicated process through the government, oftentimes through a visa, the next step is to get a green card, and these people are kind of, the terminology is lawful permanent residents. And then once you've been a lawful permanent resident for a period of time, you can then apply for citizenship and become a naturalized citizen. On the other side of the equation are people who I'm going to refer to as undocumented, and you will also hear unauthorized. So these are or illegal, or any number of other not so nice slurs that are out there. So I just wanted to say, that there's a bunch of different ways that you can talk to the same concepts that have their own meanings or connotations, and where I'm going to be on this. I wanted to also provide some background on your situation that you're practicing in here in Oregon. So what are the numbers looking like? This is some information from the Pew Research Center from a couple years back in the wake of President Obama's executive orders on immigration. And what they looked at the raw numbers of unauthorized or undocumented immigrants in 2012, and what they found is the estimates were that there are approximately 120,000 undocumented immigrants in Oregon at that state of time, which puts it at about 15 in the country. And then they looked at the people who were eligible prior to Obama's executive order for who were protected from deportation, and then the people who became newly eligible. So they found that there were 50,000 people who were newly eligible for protection from deportation through that executive order. To flesh this out a bit further, from the U.S. Census, the estimate is that there are, people who report that they were born in another country, almost 85,000 people in the Portland area who were born in another country. The picture on the left is from a rally back in November of 2014 after Obama's executive order, who are people who are working here as migrants and their experiences and the controversies that are out there around whether that was the right thing to do, what their current circumstances are as people who are filling really important roles in our economy. On the right is a picture from this organization called VAWS, and it's a workers' rights education project that actually has a community center, the Martin Luther King Jr. Community Center, that is a place where migrant workers can come together to build community, to find employment, and to actually collaborate. They've actually done a lot of work for people who were unjustly they were not paid what they were told they were going to be paid, and they've been able to advocate to get the fair compensation that people were promised. So they're just some local organizations. I want to say also as background that in a room of this size, I know that there are people that are coming from very different sides of the spectrum politically on how you might think or feel about these issues. That people who may be very supportive of Obama's executive order, or there may be people who think, we've gone too far with this and we need to kind of cut things off. And this is a very poignant debate that's happening in the public sphere right now in the United States. So I want to just name that, not to be Republican, but elephant in the room. What I want to focus on this talk is not the politics, but the individual patients who are in front of us, who are immigrants, documented or undocumented. And not just the individual patient, but as we think of in palliative care, the whole unit of care is the family, the friends, the social network that's around that person. How do we take the best care possible of this person who's an immigrant, who's in front of us, who's in our hospital bed, who's in the skilled nursing facility, who's in clinic with us? How do we provide patient-centered, compassionate care with the circumstances that person finds him or herself in? So to provide some background on undocumented immigrants, who are they? So we have now about 11.3 million undocumented migrants who are living in the U.S. according to Homeland Security from a couple years ago. 3/4 of that population is Latino. The predominant country of origin is Mexico, with much smaller numbers from El Salvador, Guatemala, and Honduras, followed by the Philippines. Most of this population is young. They're between the ages of 25 to 44. Of that younger population, slightly more are male than female. And I love this, more of the quote-unquote older undocumented migrants over the age of 45 are women. What we find is that these populations are not evenly distributed across the United States, as you might imagine. The vast majority are in California and Texas, and then followed by the kind of three very close runners-up, Florida, New York, and Illinois. This is a very interesting thing that I didn't know about until I actually dug into this topic a little bit farther, is that there's a trend happening where when people think about undocumented migrants, they might think that these are people who just got here to work. And actually, that's not the case. As of 2003, the proportion of people who are here for less than 5 years, who are recent arrivals to the United States, is now down to 16% of that total population. The vast majority have actually been here for 10 years or more. I think this is really important as we're thinking about where do people identify as their home? Is it their country of origin? Is it the United States? What does that mean for them culturally and their kind of degree of acculturation to the United States? Fleshing out a little bit of the populations of people who are documented versus undocumented. So legal permanent residents, these are green card holders. Again, Mexico is the largest population. So again, if there's, I think, a lot of assumptions or kind of things that happen in the popular media that people who are immigrants who are here from Mexico or Latin America are all undocumented, and actually the largest population of documented immigrants that are here are from Mexico. And then followed by more Asian countries, a lot of people who are coming over on visas to do work who end up staying here. And then similarly among the naturalized citizens, so people who have gone through the full immigration or naturalization process, again, the largest proportion is from Mexico. In terms of access to health care, it was surprising to me that actually nearly half of undocumented migrants are estimated to have access to some form of insurance coverage or health care services. What they might be eligible for are actually employer-sponsored insurance in some situations. Everywhere people have access to emergency Medicaid. Some places, they have access to long-term care Medicaid benefits, and all undocumented migrants can get care at federally qualified health centers. Problems are, even if you're a lawful permanent resident, you've been here less than 5 years, or if you're undocumented, you cannot buy commercial insurance. You can't buy it on the health exchanges, and you can't buy it just in the typical way without subsidies. You cannot get full scope Medicaid, and you cannot get Medicare even if you've paid into it with your wages for many years. So the next question that comes up is, okay, you can get emergency Medicaid, but what does that mean? What does that actually provide? So this is the legal definition. This is what's written into law, that it pays for so it's a situation where the acute symptoms of the condition must be sufficiently severe that the absence of immediate medical attention could reasonably be expected to result in placing the patient's health in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of any bodily organ or part. So that's the letter of the law, and how it's interpreted is very different in different states. So if you are in Texas and you are an undocumented migrant and you develop end-stage renal disease that requiring dialysis, the situation is you have to wait until you have an emergent indication for dialysis and go into the emergency department and get emergent dialysis. Every single time you need dialysis. And this is so ridiculous that what happens is the dialysis nurses who get to know these patients actually as like their regular dialysis patients will say, eat a banana before you come in. So we are sure that your potassium is up what it needs to be in the very, very dangerous range. There are other states where they actually, so you can get dialysis in California and New York and North Carolina, and in New York you can also get even chemotherapy and radiation. But it's this kind of unique thing that states have to decide how they run their Medicaid programs and use their scarce resources. I wanted to talk about another thing that oftentimes is healthcare providers for not social workers. People don't know about this, but this PRU-CAL is permanent residence under the color of the law. So this is not an immigration status, but it's a designation that identifies people who are undocumented migrants. And what it does is it says, I am willing to say to the government that I am here and I'm undocumented, and I'm then able to get these certain benefits. And the government says, we will not deport you. And this is often for people who are refugees, but if you have a serious medical condition or a terminal medical condition, we typically do not deport these folks. So it's a way of kind of getting services for people who otherwise can't get the full scope of services that they need. What about hospice care for people who were recent residents, lawful permanent residents, and people who are undocumented migrants? So the first thing, of course, is to screen for your eligibility for Medicaid, because particularly for emergency services, or if you can get the long-term care coverage, that's really helpful. But even if you can't, if they have no access to regular insurance, then hospice agencies are actually obligated as part of their certification to provide some proportion of charity care. So some of the organizations that I work with and safety net hospitals have developed a relationship with hospices where they say, we're going to refer, if to be a provider of choice for our population, we will refer our insured patients to you, but we're also going to refer our uninsured patients to you, and we expect you to provide coverage for that whole group. There's some inpatient hospice facilities in cities that have designated beds for people who are uninsured or who are undocumented. So that you would think that that's a really actually small number of places, but surprisingly, there are a lot of places around the country that provide this. So it's good to look into, and other places may have a sliding scale for accommodating people who don't have insurance. I want to talk also, even if you can surmount those logistical and insurance barriers to getting hospice care, what are the additional barriers to getting someone who's terminally ill and undocumented, getting them hospice care? So we know that for people who are not white, that there are lower enrollment rates in hospice. And a lot of people have speculated on what are the root causes underneath that. So there certainly are cultural barriers to hospice in a lot of situations. So if you are someone who has come from a situation where you've been denied access to health care for a long period of your life, and suddenly you're in a place where you actually have access to amazing healthcare services, why would I deliberately choose to limit the care that I'm going to get? Is one kind of reaction that I see sometimes. When people are sometimes approaching the end of life, their family members, particularly I find in certain Asian cultures, there's a sense of duty to pay respect and to care for your loved ones that sometimes means the longer that you're here on this earth, the more opportunity that I have as your son, as your daughter, to pay back the debt that I have, that all the things that you've done for me. And so I might make a decision or authorize more aggressive care in the intensive care unit because that might give me more time to fulfill that duty. If people who are undocumented, they may fear disclosing health information, or people may be afraid that talking about prognosis and things are going to take away hope. So by definition, we're talking about hospice, we're talking about a terminal condition. So let's not talk about the fact that this is terminal. And then if you're coming out of a culture where paternalism is more of the norm, where the doctor makes the decision around what we're going to do, and we are coming at you with this, well, what do you want? What's your choice? Well, how are you guiding this? It's kind of jarring. On top of the cultural barriers, there also are linguistic barriers. So we know that there really are often limitations in the materials that we have talking about hospice services in other languages. Oftentimes, hospices have limited bilingual staff, and a family might not feel comfortable talking with someone who can't communicate with them directly, or is saying, well, we need someone in the family to act as an interpreter. That's another barrier to welcoming an outsider into your home. And then I like to specifically highlight the fact that hospice is a concept that's used in different countries, but is used very differently. So one kind of classic example that I like to highlight is the word in Spanish that often is translated from hospice is hospicio. And for people, are there people who communicate in Spanish and kind of use that word? Yeah, we have one. Can you tell us a little bit about what does that word kind of bring up? What are the connotations?
Okay, we'll speak specifically like from Mexico.
Yep.
People heard the word hospicio.
Yep.
And it's a place, it has very wrong or bad meaning.
Yep.
Because people think it's going to be a place where you're shooting people away.
Yep.
And they cannot be taken care of by their own relatives or family.
Mm-hmm.
So it's a wrong word to say.
Yep.
Hospicio, bad, yeah.
Yep. So I don't have that kind of cultural understanding that kind of is evoked when someone hears that word. But what I kind of translate in my mind as, a lot of kind of people from kind of the culture that I grew up in is, I don't want to go to a nursing home, but that like times 5 to 10, is like a place where you're abandoned, you're kind of left for dead with people who have mental illness and, who are really challenged. So you can imagine if I kind of say, hi, I'm Dr. Kinderman, and I have this excellent type of care for you. It's called hospicio. No, thank you. I don't want that. So knowing that is a really important thing for me. So what I do is I say, when I'm talking with someone who is a monolingual Spanish speaker, I'm very deliberate about it. And I talk about the concept first, talk about the services that are provided and all of that. And I do this a lot of times with English speakers too, but particularly in this situation, I talk about the concept and exactly what's provided. And then I say, and here's what it's called. And so then I say it's called hospice. And then the interpreter interprets. And then I say, full stop. You may think of certain things when you hear this word, but this is something that's very different in the United States. It's hospice, not hospicio. So lastly, when I talk about some of the social and emotional considerations for people who are here as immigrants, if you've come to the United States specifically for the hope of work, and then you get really sick, what does that mean to your concept of how do you survive and your identity as a person? Particularly people who are supporting a whole range of dependents that are maybe here in the US, maybe back in their country of origin. So you're not only kind of failing yourself, but you're failing this whole group of people who's depending on you. If you're here to work as the first person from your family coming over, you often can be really isolated from your support network and potentially caregiver network. And then lastly, if you are undocumented or if you're living with other people who are undocumented, you might have a lot of fear of exposing yourself or those other people that you're living with and depending on to potential deportation. So it's a bunch of background, but this is about real people and real patients. This is not a picture of this patient that I'm highlighting here, but this was a study that was done at my hospital a number of years ago where at the time, medical student went and interviewed people in the hospital who their providers thought they would not be surprised if they had a year or less to live. And just interviewed these people about their experiences. And we have a large immigrant population that we care for in my hospital. And one of these gentlemen who is from El Salvador, his reflection was, I'm sitting here by myself, and just like everybody else, I need the company of somebody and to have the family. I need my family too. So it's not just, other people who need family. I also need family, and I need to be heard, and I need to be understood. So it's about real people and the patients that are in front of us. So what I would love is for now, after I've talked at you for a little while, for you to talk with your neighbor about these things. Think back to the last immigrant patient that you cared for. Was this person documented or undocumented? And how did you know that? Did you know what their status was? Did you notice that there were any linguistic, cultural, or logistical barriers to providing care? And what were those barriers? How were they addressed? And then did the patient have family or caregiver support? And were there any specific challenges that you encountered in communicating or coordinating care with them? So let's just take about 5 minutes and talk with your neighbor and do some reflection on that. Can we wrap up? So I'm really glad that you're able to kind of talk through some of these challenges, because I think that a lot of times we're really stuck in the weeds of taking care of individual patients and things, and not have a chance to really process and talk with colleagues about the things that are challenging. What were some of the things that came up in those conversations? Yeah.
The issue of interpreters that might not know the dialect, and the issue of losing family members that may not be telling what the doctor is saying,
Yeah.
telling what the interpreter is saying to the patient, because of the fact that they might not be hoped for the patient to survive much longer, and that is a huge issue.
Yeah.
Of course, the board for many immigrants, from Africa, from Mexico, from China, that issue of privacy, of, now you're telling me the truth, but I'm going to hold on to it. I'm not going to tell the patient.
Absolutely. Yeah, there's a lot of fear around that, and actually, one of the things that I like to, that's I think a very specific kind of related but somewhat separate discussion around working with interpreters, something very near and dear to my heart that I'm speaking on a bit tomorrow. But what I like to do is to unpack that a little bit with the family members proactively, especially when they say, I don't want you to tell my family member X, Y, or Z, is to really understand what's underneath that, and a lot of kind of cultural taboos, and beyond even taboos, but actually in some cultures it feels like a curse to actually talk about something. You're actually making it happen faster than it might naturally happen, and addressing that and saying, what are you worried about? Because actually what we've found out when we talk with patients who get partial information, so patients know, right? They know something is going on with them. They can feel it. They feel it much more than their family members do. And actually it really erodes trust, and it erodes hope when people get partial information in a lot of circumstances. So big issue. And just the other plug that I would say is actually access to interpreter services is actually mandated. It's required by law, especially if your population exceeds 5% or 1,000 people in a given catchment area, whichever one is smaller. So that's something that the system actually is responsible for. Yeah.
We talked a little bit about a patient who's dying but wants to go back to their home country,
Yes.
and the process of getting them there legally versus getting them deported, and how do you honor them and but also not disrespect them getting their needs met.
Yeah, I'm going to definitely, you're playing right into my hand. We're going to talk very specifically about the request to return to your country of origin a little bit. Other things that came up. Yeah.
Yeah, we took also that immediately with follow up in the conversation with the interpreters, they see a Hispanic or Spanish or Latino person, and immediately we all assume they must speak Spanish. So they hired a Spanish-speaking interpreter, and they provide the services when many times the patient was not even able to speak Spanish. It was a dialect, but we were not able to address that fact. And every country, every Latino, every Spanish-speaking country has their own dialects. And for example, I will say use Mexico itself. The Department of Public Education acknowledged like 68 different dialects. So that is impossible. That is a lot of work for us. And, how can we expect for everybody to be knowledgeable enough to be able to address all those little things?
Yeah, and it's really hard when there are kind of smaller immigrant communities are just forming, and they haven't reached that critical mass yet. I will say that there's a county in California not too far from where I practice. It's Natividad Medical Center that actually has developed really robust services with indigenous language groups because that they have reached that critical mass, and they feel like it's not conscionable to not be able to provide that.
Yeah. One more thing then we see, and then I give the microphone to somebody else, is many times when the client is to the point of end of life, per se, so the clients not understanding what benefits or what resources or what options are available for them in there, they think, I just want to request to extend their life as long as I can. But in the other thing, when you see the reality is, they have so much fear of the not knowing what to do after this patient, this family relative passes away, die. What is it that we need to do? Because, they are not prepared. They do not have any life insurance. They don't have money to do through all those expenses, the birth, and they don't even know how to start. What would be the first step after somebody passes? So, filling up or getting all the information we can about resources and rights and options that they can get, it will make their life easier and ours as well.
Terrific. Great. So more conversation to come. I want to start moving into some of the issues, common end-of-life issues, some of which have already been raised, but dig into them a little bit more. So I'm going to talk about a couple of patients that I've taken care of in the last couple of years. So the first case is of Mr. V. So Mr. V is a 48-year-old Spanish-speaking man who was recently diagnosed with metastatic sarcoma of unknown primary origin. He's being readmitted with severe pain in his abdomen and back, and CT scans reveal increasing size of the tumors throughout his abdomen. He had been estranged from his wife after years of drinking, but recently reunited with her when he became sober. His wife works part-time now, partially because she needs to take care of her husband and his increasing pain needs. So what I want to do is to try to provide you with a framework of thinking about how do you provide care for immigrants, whether they're documented or undocumented, and particularly highlight some of the issues with undocumented immigrants. Give you some ideas of the questions that you might want to ask, and then talk about practical ways to meet the needs and requests that they make, specifically returning to the country of origin and getting end-of-life care in the U.S. if people don't have insurance. So first is knowing the issues. So there was a nice review article in the Journal of Palliative Medicine just last year outlining the common issues that come up for migrants who are approaching end of life. So there's this idea that I highlighted before around dual identities of the identity of my country of origin and the culture and the traditions from there, and then the culture of the United States and what is available here, how do people approach the end of life here. Oftentimes, as people are coming to the end of life, there's a lot of reflection and thinking about what's meaning to me and how have people in my family, what has end of life looked like for them, my neighbors, my friends, and traditions in my country of origin. And then specifically around dying and what that process looks like, there may be specific concerns about where exactly that person dies, whether that's here in the United States or in their country of origin. And then beyond that, even if someone dies here in the United States, they may have a strong preference for their remains to go back to their country of origin. Specific rituals that they may want done, and then how are they going to be remembered by their family in the subsequent years? These are things that migrants were reporting in this study. Other things that I want to highlight are the cultural barriers that are specific to caregiving, and an illness and death may actually make care at home at the end of life uncomfortable or just not possible. So I take care of a large population of Chinese American patients in San Francisco, and for many of them, they are renting apartments, and sometimes legally, sometimes illegal apartments, and people are often concerned that their landlords will kick them out if someone dies in the apartment, that there's this kind of idea of there's a bad spirit that's there that's kind of made the environment bad, and then they'll lose their housing. So a lot of times people will want to get care from their family members at home, but they don't want to die at home. The reluctance to accept home services may also be, as I mentioned, the logistical reasons around there's someone who's undocumented, who's there, and so I don't want to give you my address and have people, strangers coming in who might report us. The financial strain around if you are working as a day laborer and now you're not physically able to work anymore, or you're not working and your partner or your other people around you are not able to work because they're having to care for you, that can make you really financially vulnerable in a very short period of time, where you are losing your housing or you don't have enough money for food. Other issues that come up is time and time again is the separation. Oftentimes, it's sometimes happens that an entire family relocates to the United States over time, but in many, many situations, there are family members who are still in the country of origin, who people haven't seen for years, and they want to connect with those people. And then, as I kind of alluded to earlier, is this idea of I'm coming to the United States for a better life, for not just for myself, but for my family, and this idea of I am a failure because I'm not continuing to be a breadwinner for my family. So it's identity and kind of this financial survival of your family. Other considerations, particularly for the undocumented, as I mentioned, not providing correct address or phone information, refusing home care services, and it's hard sometimes to even get home care services with limitations in your insurance. And then particularly finding someone who's willing to be a healthcare proxy. So what I find is that people kind of put all legal forms kind of in one bucket. And they'll kind of say, I'm not going to sign a healthcare proxy because that means I'm going to be financially responsible for the cost of end-of-life care. Or I'm not going to put my name on a legal document because then immigration is going to find me. So there's a lot of fear and distrust around specifically legal documents. So what I want to do is to try to equip you with these are some things that you might want to ask about when you're taking care of immigrants who are approaching the end of life. So just like taking care of people who were born in the United States, thinking about uncontrolled symptoms and not just what they are, but how are they actually impacting your life? How is this impacting your ability to work? How is this impacting your ability to get around? How is this impacting your ability to do things that you enjoy? How does this person conceptualize illness? Do they understand what's going on, or do they have a totally different narrative around what caused my cancer, what caused my liver failure? How does this person like to receive information? I think we make way too big an assumption that everyone does well with just me talking to you and you absorbing that information, just listening. There are a lot of people who don't learn well that way. And so they might need written materials, they might need pictures, they might need videos, they might need someone else taking it down and explaining it to them in a very kind of deliberate way over time. Asking about their hopes and fears about the future, about how that person likes to make decisions. Do they like to make decisions with the healthcare provider, really taking on a very prominent role in recommending what should be done? Or do they like to make decisions as a group? And who should be involved in that group? Family members, friends, religious or spiritual counselors. What are the barriers to care, the financial and logistical barriers to care? And then what's their home situation like? Who are caregivers? Some of the unique considerations for people who are immigrants, specifically asking about their country of origin and their length of time in the U.S. Someone who's been here for a year or two is entirely different from someone who's been here 25 years. There are some people who are here for a long time and they don't acculturate very much, but a lot of people identify much more as Americans than they do kind of their country of origin. The only way to know is to ask about that. What's their preferred language? I think a lot of times, we try to kind of get by with the you speak some English and you kind of understand me. But in having these conversations, what language are you actually most comfortable in? What do you prefer for having these conversations? Where is this person's family? Are they here? Are there some family members who are here? Are there family members who are in other parts of the U.S.? Are they in the country of origin? And then I like to ask about when was the last time that they visited the country of origin or saw the relatives who are remaining there. And very specifically, I'd like to ask about any desire to return to their country of origin, either before they pass away or after, because you really need to plan in advance very deliberately for those kind of requests. So I'm going to bring us back to this case of Mr. V. So again, he's a middle-aged, married, Spanish-speaking man who has recently diagnosed metastatic, this is a sarcoma that he had, not a carcinoma. He was unable to work, it turns out, because of his pain issues. His family is predominantly in Mexico, but as I mentioned, his wife and a couple of children are here. As you're getting close to discharge, he declines home care services, even though you think he really could benefit from it. So I wanted to ask what questions you might want to ask Mr. V and his wife in this situation as you're planning for discharge. So just take a couple of minutes and talk with your neighbor about what type of questions you might want to ask. So these are some of the things that come up just in the interest of time, assuming that you guys did an A or A+ work in asking different questions about him. So you start to uncover some significant financial strain because we've lost his income and we've also lost most of his wife's income. So that's a huge burden on them. You learn that Mr. V is actually undocumented, and that's also a source of stress for them and thinking about healthcare services. When you ask about desire to return to his country of origin, he actually kind of lights up and says, yeah, I've really been dreaming that I could go back to Mexico and visit my family. And what he says is, but I really want treatment for my cancer. So how do I navigate that? How do I think about going back for a visit to Mexico and also getting my cancer treatment? And he's worried about how does he manage his pain and his symptoms when he's there. So I'm going to spend the next chunk of time talking specifically about this request to return to the country of origin, either as in Mr. V's case, his desire was to go and then return for more treatment, but in some cases that's a desire to return for end of life. So why do people want to return to their country of origin as they're approaching the end of life? So one thing is that it actually may be important culturally or from a spiritual standpoint for them to have their final resting place be in their country of origin. And what it turns out, it is substantially cheaper to actually buy just a plane ticket to sit in versus returning someone's remains to their country of origin. So just from a really logistical standpoint, it's a lot more feasible for people to return before they die. They may have a lot more family in their country of origin who are actually around and able to care for them. So again, just logistically, they may want to be back there. To go back to the place that you haven't been for years and years and experience and see all the things that you remember there is a strong draw for a lot of people. And to reunite with friends and family, of course. Some of the big barriers are cost. So buying a plane ticket, oftentimes not just for yourself, but for someone to accompany you if you're frail, is out of reach for some people who are flying to faraway countries of origin. And then the physical or medical limitations to travel, which we'll go into. So this is a really key part of talking about someone's goals of care. And when I talk about this with patients and families is to say, what I hear a lot is I want to get kind of treatment for as long as possible here in the United States because you have amazing treatments here, or we have amazing treatments here at the, in the United States. And then I want to go back, kind of for the very end. And I totally understand that. But the problem is there is often a limited window of opportunity to go back. If people wait too long, then they're too sick to return. And there's some times where people say, that's an okay risk or trade to make. I want to know, it's more important for me to know that I got treatment as long as possible and miss that window of opportunity. And for some people, they'd say, I actually would much rather be home and, potentially miss out on some aggressive treatments here, but know that I'm going to get back. So it's just an informed kind of consent and risks and benefits kind of conversation. And then you want to plan ahead and think about what type of support do they need both during the travel to their country of origin and when they get to their country of origin. So one of the first kind of things is, can this person actually even tolerate travel? So think about their mental status. Are they going to be able to sit up in the uncomfortable, commercial, increasingly limited space airline seats that we have nowadays? Are their vital signs relatively close to within normal limits? And if they're using oxygen, how much oxygen do they need? Usually when you get up kind of in the compression of air, if you're on more than kind of 4 or 5 liters, it's pretty dangerous. You can get oxygen during flight, but there are limits to what you can actually reasonably deliver. The ability to take in fluids either by mouth or by feeding tubes is an important thing to think about. And then there are a bunch of relative contraindications on the handout that hopefully you all picked up. There's a checklist there, and one of the first things has relative contraindications like very recent surgeries, very recent strokes, or myocardial infarctions, or behavioral issues, or mental status things. So they aren't hard contraindications, but they're relative. And then the other thing that I think about is there anyone who's able to accompany the patient? By and large, the people that I'm seeing flying by themselves would not be a good idea. So just someone to navigate through the system and to actually help you get to the bathroom if you need to on the plane, get your needs met. It's often really important to have someone to fly with the patient. A good idea, once you've decided that this person is medically able to travel, is to contact the embassy or the consulate to determine if repatriation support is available. Actually, the Mexican consulate is great, and they actually will pay to help to get people back to Mexico in a lot of situations, either before or after death. Does this person actually have a passport or ID? And if so, if not, how do you get some sort of identification so they can get on the plane? Thinking about travel, really encouraging direct flights whenever possible. They're not always possible. And when they're not possible, what is the patient going to need on the layover? Trying to, either think strategically around, do they need a little bit of more time on the layover? Do they need less time on the layover? Trying to strategize around that with the patient and family. Once they make the arrangements, getting the flight information so that you know when they're going and what that's going to look like. Talk about what's going to happen once you get there. Are you now going to get on, is the plan to get on a bus that's going to go for another 10 hours? Or are you going to be in the capital city and that's where you're going to stay? So it's important to think about how you can support them, not just to their country of origin, but then beyond. And then contact the airline because they actually have limitations on who they're willing to take and what type of support services they have for people. So things to think about, particularly when people are hospitalized, is what consult support might be helpful. So things like physical therapy. Do they need any assistive devices, walkers, canes, other things to get around? And helping with mobility. Can we increase strength a little bit to help improve things? And getting a nutrition consult potentially for if someone has needs for artificial nutrition and figuring out what that's going to look like. Needs for oxygen and durable medical equipment. One thing that people I think don't often think about is, how do you deal with the fact that you need to get up and go to the bathroom in those narrow aisles and small bathrooms on a plane? And the particular bugaboo of dealing with end-stage liver disease and people who are on lactulose. So kind of walking this tightrope around, if you don't take your lactulose, then it's good because you probably don't have to get up and go to the bathroom so much, but then you're going to get altered if it's a really long flight. So trying to kind of navigate how long is the flight going to be, who's going to be with you, how much are we going to kind of adjust that. But things like maybe holding their bowel regimen that day so that they don't go, and then kind of counseling the family on getting that restarted after they get there. Things about diuretics, so just things to think about. Trying to tighten up their med list, and whenever possible, using medications that they can actually get in their country of origin, making copies of medical records and imaging, writing a letter that kind of does a summary and telling to whom it may concern, this person does not have an infectious disease, that they're going to communicate on the plane, they're fit for travel, we've counseled them on these things, and this person, their code status is DNR, DNI, these sorts of things. It's not a guarantee. You need to tell the patient and family that this doesn't mean that everything goes perfectly well, but it's better than not having a letter. And then whenever possible, having a 30 or 90-day medication supply. I want to highlight that a lot of countries have very limited to minimal access to opioids. So particularly, pain management at the end of life can be really problematic. And so getting as much of a supply as you can and doing lots of counseling around that is something to think about. Just to highlight a couple of centers in the United States that do this quite a lot. So this is a study case series from Bellevue in New York, where they looked at 17 patients with advanced cancer who wanted to return to their country of origin. We call that medical repatriation sometimes, not a term that I'm in love with, but it's the shorthand. 16 of the 17 people made it back to their home country. Most of those people were not on oxygen, they were not in severe pain, and they didn't have altered mental status. So it's a good thing kind of thinking about who were the successful people who got there. And they thought, not surprisingly, it was helpful to have a protocol in place to think through these issues before trying to send someone. There was a bigger study that was done at Cook County Hospital in Chicago, where they looked at 60 patients, and they looked at what were the predictors for people who successfully returned to their countries of origin. And one of the handouts that I provided came from this group and their checklist that they use to think about who's able to travel, and then what are the things that you need to do to prepare. So returning to Mr. V's case, with support from the hospital team and his oncologist, he actually successfully visited his family in Mexico, had a fantastic visit. The next time I saw him, he just lit up talking about it. And he came back to the U.S. because he wanted more cancer treatment. And he really, for him, a good death was as much kind of aggressive care as he could get before end of life. And he had a course in the ICU before transitioning to comfort care and passing away in our hospital. The next case that I want to talk about is Ms. Y, another patient that I took care of in the last year. So she's a 65-year-old Amharic-speaking woman from Ethiopia who was relatively healthy until she was recently diagnosed with a diffuse large B-cell lymphoma. Her family insisted on acting as her interpreter and communicating on her behalf. So even if I really attempted to try to engage and ask questions directly to her as I would with other patients, they would kind of interpret, to say, oh, she's this or that, and it was really hard to get across that barrier. But as part of our goals of care discussion, asked specifically about desire to return to her country of origin, and they said yes, that would be a good death for her, would be to get back to Ethiopia. But in the meantime, they wanted to pursue aggressive cancer treatments. So she started her first cycle of chemotherapy, which she really couldn't tolerate. I mean, she just had complications. She got neutropenic, she got infected, she was altered, she just did about as poorly as one can do, and she became obtunded. And so we were then in the situation of wanting to discuss where to go from here, because her death seemed to be imminent, but there was no way that she was going to be able to tolerate travel back to Ethiopia. So my question again to kind of for you to talk about with your neighbor for the next couple of minutes is how would you address this with the family when their end-of-life goals that they had hoped for cannot be met? And what would her options be if this patient were with you here at Providence? How would you counsel them about options for her end-of-life care? All right. Again, so love the discussion. In the interest of time, we will move forward and do this last chunk of information or suggestions, and then open things up to questions. So these are things that I think about when return to the country of origin is not feasible. It's desired, but it's not feasible. So the first thing that oftentimes is a huge draw for people in returning to their country of origin is that connection with their loved ones. Phone is is the easiest and most accessible. And I oftentimes am in the situation in the intensive care unit or in our comfort care rooms when people are in the final hours to days of life, where I'm counseling family members. One of the senses that stays with us the longest is actually hearing. And so even if your mom cannot talk back to the person on the other side of the line, the person who's in the country of origin may have something they really need to say to her. And so it's okay to put the phone up to her ear and allow that person to say the things that he or she needs to say. Video conferencing is an amazing technology that really helps to make people feel more connected, and is something that we try to facilitate with iPads and laptops that we have. Most places there's some sort of an internet cafe, or there's different apps and things that make it actually free to do it. So if you can get Skype, you can have a video conference. When that doesn't work, or if there's something else that people want to communicate, not verbally, but express something to their loved ones, is writing letters to them. And beyond that, if there's enough time, helping to write letters that can go to embassies to help try to expedite the process of people getting visas to come to the United States to visit the person. It's good to think about legacy activities in terms of what do you want to communicate about your life, about what you've learned, about your experience in the United States, and what do you want to pass on to your family who's in your country of origin. And then an explicit discussion around, is there a desire to have a return of your remains after you pass away? And of course, as was mentioned, what happens? We have specific information that's translated into Spanish and Chinese, because those are the predominant language groups that I take care of in San Francisco, that actually walk through kind of the frequently asked questions around what happens after someone dies, and who are the different organizations you need to contact, and who's there for support, and all of that. So lastly, I just want to wrap up talking about the issue of access to palliative care services and hospice services. So, of course, if you have emergency Medicaid, consults in the hospital are covered under that. And I mentioned already the hospice charity care. Public hospitals are there to provide care to anyone regardless of their ability to pay. So great resource when it's there. And actually, some states are looking for, the Affordable Care Act very explicitly says that undocumented migrants cannot access healthcare through the exchanges. But actually in California, we passed a law last year that allowed counties to decide whether or not they would let undocumented immigrants buy insurance on the exchanges. So some of our counties have decided to allow that, because our Medicaid program is county by county. So we get really hyper-local on that, and so some they'll allow people to buy it and some won't. Other ways to expand access, working with collaborators like, as I mentioned, consulates and embassies, developing those relationships with your local hospice agencies, particularly that have the cultural competence to help care for people. Developing relationships with the primary care providers and emergency medicine providers to really train them up in generalist palliative care, because these are places where a lot of people who are, particularly if they're undocumented, will frequent more kind of emergency services not by choice, but kind of by that's their primary means. And then what are the hospice or bereavement resources that are actually culturally competent or linguistically concordant for this patient or family? There are some religious groups that actually provide charity care and provide either an inpatient hospice facility or other kind of outreach to people who don't have the ability to pay, and some of whom are undocumented. And then what are the support that's available for family caregivers? There are other granting organizations that particularly focus on palliative care, hospice, or migrants, or the uninsured, that may be relevant to help build programs and services. Specific religious or cultural groups can make grants to help care for a particular population. At Bellevue, my colleagues got a grant from the Samuels Foundation to start up an outpatient palliative care with the understanding that this was going to include uninsured patients, some of whom would be undocumented. And it gave access to palliative care for people who have just emergency Medicaid who usually couldn't access these services. So I wanted to make another plug for that, the handout that has the detailed protocol, and there's another handout that kind of summarizes a bunch of the information that we went through today. The resources that I have here are listed on the handout as well. With that, I wanted to just say thank you so much for inviting me here to talk about this, and I would love to have the remaining time open for questions. Yeah, so sorry, to repeat the question is, in our first case, the gentleman who was undocumented, how did he get back to the United States? So it's a good question. I don't know when his visa, so there's kind of, he had an initial visa that I think had expired, and whether he could get another, I'm not sure, but there's kind of a line, I have to say, with me as a provider where it's a don't ask, don't tell a little bit. I mean, it's something that we talk about with people, but I try to provide a kind of a trusting environment where saying, I want to know, I'm a safe person to talk to you about your immigration status. I'm not going to report you, but I can't kind of go the next line and kind of logistics of getting back into the country.
Loud enough, but but I would say, on the other hand, we see clients and you recommend for them to go back to their country, but because they would like to come back, but the legal status would not allow them. Mm-hmm. So they know if they get out of here, they cannot come back. Yeah. So I'm still not knowing how an undocumented person will be able to return after they get a little well used for the treatment, as we saw it on the, on that information you gave us. So I don't know. Well, I know that we don't have the wall yet. That so maybe that's. I'm sorry. Yeah. Okay.
I wonder how much do you advise people about the medical care that might be available in the country of origin, and do you have a resource for how you know if it's any good or not?
So it's a great question. So among the resources, there is a listing for kind of hospice and palliative care organizations in countries all over the world, and I certainly I try to have as open a conversation with people as I can and say, like, I am not the expert. You are probably, in your family, are the experts at kind of finding out what's available on the ground. And here are the general principles of things that I've kind of seen, or problems that people have run into, and what is available for you. And that definitely comes into play in terms of what the decision making around whether people return to their country of origin. But happy if Meg has any thoughts too.
I do. So in the rest of the world, if it's not a first world country, if you have money, you can get care. And if you don't, you don't. So regardless of what you can find on the websites, local knowledge is definitely needed, but it is ultimately about the haves and the have-nots.
There's no EMTALA in other countries that kind of mandate that you have to get care when you go in for emergency care.
You spoke about medical repatriation, and I'm presuming that was desired repatriation. Can you comment on forced repatriation?
Other than it's really scary to me, I know that it happens in certain states where people are, particularly they're in a really compromised state where they can't kind of speak for themselves, and they're getting really expensive for the healthcare system. And I would say it's kind of on the border of legality, or kind of like certainly ethics. So it's not something, fortunately, that I encounter that ever happens in my system. But I think if I were practicing in a system where that were kind of deemed to be acceptable, I'd probably be vocal around that. Because I understand the tension, but I feel like there's a lot of low-hanging fruit on kind of care that we provide that's unnecessary that we could kind of solve in different ways. And I think we need to take some responsibility for the situations that we put people in, Yeah.
Thanks.
Mm-hmm. Yeah.
I'll just do it without the microphone. Never mind. So my question is regarding community health workers. I work as a community health worker, so I am kind of the bridge between the health system and the patients. And I wanted to know if those patients that you describe, Bob, did you have the interaction of a community health worker with the family to help ease those services?
So I'm a huge fan of community health workers, and there's now starting to be more discussion about how do we incorporate community health workers in palliative care teams, which is I think is it's kind of a duh, because there's so much that it's interesting because I think about what are the things that I actually kind of have permission or ability to do as a white woman, American citizen, that my colleagues who are maybe culturally, linguistically concordant, it wouldn't be okay for them because they don't know any better. But to say, and not to say that I'm trying to cross boundaries, but to say there are certain times that I feel like people are overly protective because they're like, this is not something acceptable to talk about, but actually the person really wants to talk about it, So I think, but in most cases, it is, you just find out so much more, and you have so much more trust and ability to engage with a patient when you have someone who understands the culture, who can communicate freely and directly, who can visit them at home. So it's absolutely something, I think it makes a ton of sense. And we have really limited kind of patient navigators that are accessible to me. What I try to do is always to find out when I have a new patient I'm taking care of about who is the care team that's involved in this person's care, the primary care provider, the specialty care providers, the case managers, the community health workers. Find out who all those people are and bring them together to understand how to best support this patient and this family. So unfortunately, in Mr. V's case, there was not a community health worker that had engaged with him. I was really fortunate that the social worker who'd known him from the time of diagnosis. His oncology social worker spoke to him, was able to communicate with him directly in Spanish and with his wife, and so that decreased some of the barriers, but it certainly wasn't the same as having someone who he could really identify with.
We have time for maybe one more question or comment. Okay. Well, then I'll go ahead and thank you very much for this very engaging